Welcome. My name is Roger Citron. I am the director of the Drug Use Research and Management Program, and my team helps administer these P&T committee meetings. This meeting is being recorded. It will be posted to YouTube and hosted on the OHA's website, so you can go back and visit this at a later date. Included will be the minutes and eventually the recommendations from the director of the OHA. So with that, there's some announcements on the guidelines here. Again, for those that have joined, if you're able to, please add your name and affiliation so that we can accurately reflect that in the minutes. With that, we're going to start off with roll call and introductions. I did not see Pat yet, so as one member, I just peruse below. I know he was going to join us, so as soon as we see him join, we'll let him introduce himself. But let's turn it over to you, Kat.
Hi, this is Kat Livingston, Healthcare Medical Director, Practicing Family Doctor.
Welcome, Kat. Thank you. Stacy is our chair.
Hey everybody, I'm Stacy Ramirez. I'm faculty at OSU College of Pharmacy and then a clinical pharmacist and director of pharmacy for the community health centers of Benton and Lynn counties.
Thank you. Welcome, Stacy. Tim.
Good day, this is Tim Langford. I'm pharmacy director with the Klamath Tribes.
Thanks, Tim. Karen wasn't able to join us today. Robin?
I'm Robin Moody. Yeah, sorry. I'm Robin Moody. I'm a P&T committee member. Thank you.
Thank you. Bill.
Bill Origer, family medicine, faculty, family medicine residency program at Samaritan Corvallis.
Great, thanks, Bill. Mark.
If I can find my mute button, there we go. I'm Mark Helm. I'm a pediatrician in Silverton, Oregon.
Great, thanks, Mark. Russ?
Hey, I'm Russ Huffman. I'm a psychiatric nurse practitioner with Salem Health.
Welcome, Russ. And Eddie?
Hello, good afternoon. Eddie Saito, associate professor with the School of Pharmacy at Pacific University and clinical pharmacist with Virginia Garcia.
And we do have one vacancy in this current year, but we're excited to hopefully have some people that are being interested for appointment next year. So with that, we'll move on to staff introductions. Jennifer?
Yeah, Jennifer Bowen, Executive Support Specialist, Oregon Health Authority.
This is Roger Citron, again, OSU College of Pharmacy, Derm Director.
And this is Trevor Douglas. I am the Pharmacy Director for the Oregon Health Authority.
Hi, this is Dave Ingen, clinical pharmacist for the OSU Derm Group.
Hi, this is Sarah Fletcher. I'm one of the P&T clinical co-coordinators for the Derm Group.
Hello, I'm Andrew Gibler. I'm the clinical pharmacy manager at Oregon Health Authority. Also have a small faculty appointment with OSU College of Pharmacy Derm team.
My name is Kyle Hamilton. I'm the pharmacy drug coordinator with OHA.
I think Megan's out. This is Deanna Moretz. I work with the College of Pharmacy and the Derm team.
And I don't think Amanda is able to join, so Kathy?
Sure, I'm Kathy Santana, and I'm a clinical pharmacist with the Derm team.
And my name is Sarah Servid. I am a P&T clinical coordinator working with Sarah Fletcher for the Derm Group.
I'm Lance Starkweather. I'm the pharmacy manager for Gainwell Technologies.
And I'm Dee Weston, Pharmacy Program Policy Advisor with OHA.
Hello, my name is Brandon Wells. I'm the Pharmacy Program Analyst for the Fee-for-Service Program at OHA. Thank you.
Great, and Ted Williams is not joining us today either. He has a small appointment with the Derm team. So with that, we'll go on to the conflict of interest declaration. Vitally important to the OHA that we understand conflict of interest and those are disclosed. All members of the committee and all staff members have a conflict of interest form filled out and on file with the OHA. Any changes those are expected to be updated. Anybody providing written or public comment to the committee also fills out a conflict of interest declaration, but uniquely at this meeting, we are not having anybody that signed up to provide public comment. So at this point, just open it up to the committee If anybody has any recent conflicts that have arisen that they need to disclose to the committee, or any topics on the agenda for which they should recuse themselves. Excellent. Hearing none. For the audience, we'll put it up on the screen here, but if you're following along, we have the packet of materials posted to our website, the OSU College of Pharmacy Durham website, and we'll be moving on to page 4 in that packet of materials. We have no recommended changes to the agenda, but we have the draft minutes from the October meeting. Those were sent out to the committee to review in advance, but we'll see if the committee has any edits that they would recommend. And if not, we'd need a motion to approve the minutes.
So moved.
Thank you, Robin.
Second.
Thanks, Russ.
All those in favor? Oh, did you want me to do that, Roger? Sorry.
Yes, I do. Thank you.
Okay.
Aye.
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 Anyone opposed? Thank you.
Awesome. Thank you, Stacy.
I'll abstain as I was not present. This is Mark Helm.
We'll reflect that. Thank you, Mark. Next, we'll have the department update. We do have Andrew Gibler on the agenda, and we also are going to have a guest appearance by Trevor. So I think, Andrew, are you leading off?
Yeah, I can lead off, and then I'll pass it on to Trevor. And welcome back, Trevor. He took the month of November off. We missed him, but he's been going go since the start of the pandemic. So he earned a well-deserved break, and we're glad to have him back. So if any of you have been looking for a reply from him in the last month, you might want to email him once more and get it up to the top of his inbox. As many of you know, Pat Allen, director of OHA, has submitted his resignation. We don't have a plan for, we haven't heard of any plans for who the interim plans for the director of OHA is yet. Steve Allen, director of behavioral health, also submitted his resignation, and we aren't aware of any plans for his replacement as well. We're getting prepared right now for legislative session that starts here next month. We also are very aware of the high rates of hospitalizations for RSV and flu in the pediatric population in particular. We're aware of some drug shortages with albuterol and Tamiflu, or also Tamivir. And we're in communications with health system pharmacies, medical providers on those shortages, and working out what ways we can help mitigate or help with those shortages, mostly due to increased demand right now. The other thing that OHA has decided to do is, with the increased hospitalizations and the state of emergency declared by Governor Brown for particularly around the RSV, that we are opening up some coverage for Synagis, which is pembrolizumab. And if you may know that's a RSV protein inhibitor, a monoclonal antibody that's indicated for prevention of RSV in our vulnerable pediatric population. And our fee-for-service criteria specifies coverage for some children under 12 months and under, and then 24 months and under. And we've expanded coverage so that children with specific comorbidities that are 24 months and younger can all receive coverage. So we hope that will help prevent some hospitalizations, and we hope that will continue to promote health equity in our state, and wanted to let you know that and spread the word if you have patients or know of patients that may qualify for Synagis, that is happening right now. So any questions on that? And if not, Trevor, would you like to go from here?
Sure. Thank you to the committee, every one of you. I know it takes a lot to take this time out of your day, not just to attend this meeting, but also to prepare. And forever indebted to each of you and thankful for all of your work, which, next slide, please. I would like to just take a moment to acknowledge and recognize one of your colleagues. Today will be his last meeting as a P&T committee member. Thank you to Dr. Mark. It seems like whenever OHA calls you, you've been ready to say yes. And I don't know that it has been appropriately recognized that you always find time to serve your fellow Oregonians. Just a little bit about Mark. He brought over 3 decades of experience that melded with over a decade of pharmaceutical industry market research experience and benefit design to our committee. And prior to coming to Oregon, Dr. Mark contributed to the health of the children in his home state of Arkansas by working at a state health policy level, and initiated policies and helped improve the care delivered to Arkansas's children, including policies that led to safe and more appropriate use of antipsychotic medications, and also aligning asthma treatment to be more consistent with treatment guidelines. So we were lucky in 2013 when Dr. Mark decided to bring his expertise to Oregon. And in addition to his work with us here at the P&T committee, Mark's just been extremely involved in his community, our state, and even at a national level. You know, he's chaired the Willamette Health Council. He's been on a CCO's P&T committee before, as well as a member of a quality metrics and outcomes work group committee for a CCO. And worked as a contributing clinical member with the Board of Pharmacy's Public Health Formulary Committee, which has seen a lot of work this last couple of years. And there's numerous other national and local organizations that Mark has contributed his time and donated his time to make sure the best possible health outcomes occur for our children. And that includes children with special health needs, and also children that receive care in institutional settings. It's clear, Mark, that you have a heart for children's health care, and it's evident in the work that you've done with us. And we're so fortunate that we'll continue to benefit from your work as you devote more of your time, precious time, to your private practice in Silverton, where you continue to deliver excellence to the kids you serve there. Personally, Mark, I'll miss you on the committee. I think I speak for everybody. And it's not just because you're a terrific person. Mark, you've challenged me at times, and I've grown professionally as a result. And you've contributed greatly to this committee's success and progress. And Mark, I very much appreciate being able to call you a colleague. And I am going to take every advantage of working with you in the future when that opportunity arises. Your input on this committee and the insights you've shared with us have been helpful, always clinically sound and practical. And on behalf of OHA, I want to formally recognize you for your service to Oregon. Thank you.
Well, thank you very much. That's very kind words and high praise, and I appreciate the opportunities that I've had to help out, and hopefully it hasn't been too challenging.
I echo Trevor's comments. You've been on the committee since 2019. You've been stretched thin, and we're willing to be reappointed so that you could continue us to be afloat and maintain a quorum. But you've always challenged us, and I appreciate you helping us make excellent decisions and recommendations to the OHA. And I invite you to continue to monitor our work, look at our documents, and provide your input, because you have valuable insights and good advice and lots of experience that we can learn and grow from. So I really appreciate the time that I've got to know you as well, Mark.
Thank you. My camera's off, but if it were on, you'd see I was blushing.
Well, if we were in person, we'd be eating cake later at the break, but unfortunately, that's not the case.
think we all
right.
still need to get our own piece of cake and toast Mark, or carrot sticks or apples or whatever. I personally would choose the cake, but.
Agreed. That's right.
And Dee says she is eating cake already. So
exactly. There you go.
She's prepared. Survival kit.
Well, thank you. That's
Anything
all I
else,
had.
Trevor?
That's all I had. Thank you, everybody.
All right. So we'll be going to the consent agenda in just a moment. I did want to remind the audience that the P&T committee also serves as the Drug Use Review Board, which is a federally mandated board when states elect to cover prescription drugs. So DUR board requirements, or Social Security Act requires the DUR board meet quarterly. So we focus one meeting each quarter on DUR activities. So you'll see that in some of the reports that we have. One of those reports is the quarterly utilization report. That is posted to our website, and it's part of the consent agenda. We've gone through that previously. We also have some updates to the oncology and orphan drug policy. See if the committee wishes to discuss any of those topics, and if not, we need a motion to approve the consent agenda.
Move to approve.
Thank you, Bill.
Second.
Great, thank you.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Thank you all.
And as I mentioned, this is a DUR focused meeting, so I draw your attention to page 30 if you're following along in the packet of materials, and we'll turn it over to Lan Starkweather for the ProDUR report.
Thank you, Roger. So what we have here is the prospective drug utilization review, which allows electronic monitoring to screen prescription claims to identify problems such as potential and actual adverse effects, therapeutic duplication, drug disease interaction and contraindication, clinical misuse or abuse, drug-drug interactions, and then drug and patient precautions like due to age, allergies, gender, pregnancy, and etc. So for the third quarter, we had over 12 different ProDUR alerts that the system review, over 142,000 total for the quarter. 10 of these alerts are set to have the claim paid, while 2 are set to deny the claim. Those are highlighted in yellow. So the early refill and also the pregnancy drug interaction. The threshold set for the early refill edit is 80%, where previously filled 30-day supply is trying to be filled or refilled for 24 days, the claim will be denied. There were a total of 92,000 early refill alerts for the quarter, and over 17,000 were overridden, so that equates to a 19% override. For the pregnancy drug interaction, it's triggered when a teratogenic medication is being filled and a patient has a recent pregnancy history. Oftentimes, these alerts are false positive, and typically the pharmacist will override many of these alerts. There were a total of 32 pregnancy drug interaction alerts for the quarter, 25 were overridden, and then there were 7 that didn't have any response from the pharmacist. Next page. So this page shows the top drugs enforced in the early refill alert. It's broken down by the different types of therapeutic class based on the number of alerts received. The class with the highest number of alerts is the SSRIs antidepressants. So your sertraline, fluoxetine, escitalopram, and citalopram. We received a total of over 3,400 overrides for this class. Over 20,000 alerts were received for the class and 3,400 were overridden. The next class we have are the other antidepressants, so the non-SSRI antidepressants. This includes the bupropion, trazodone, duloxetine, and mirtazapine. These numbers are very similar to the SSRI alerts. So over 22,000 alerts received for this category of drugs, and over 3,900 were overridden. Next, we have the antipsychotics. These are your second generation antipsychotics: quetiapine, olanzapine, risperidone, and aripiprazole. Over 12,000 alerts were received, and an average percent of override is 20%. The next group listed is the anxiolytic. Buspirone is the most significant number of alerts for this group. We also monitor the benzodiazepine. Although there isn't a large number of alerts for the class itself, the 1 in 4 of the early refill alerts for the benzodiazepines are overridden. And then lastly are just other 7-Eleven drugs that are used with a large number of alerts, which is the lamotrigine, guanfacine, and then I've also included the Suboxone for the MAT treatment. Next page, this one shows the early refill reason code by month. Overall for the quarter, we had over 9,000 overrides, and 66% of the overrides were due to medical necessity, which is the submission clarification code of 7. Next highest number is due to change in therapy, which is 15.2%. And then we have 6.8% due to lost medication and 5% due to a vacation supply.
Hey, Lan, can I ask a quick question?
Sure.
So what happened in September? If you look July, August, for at least for the medically necessary overrides, did something change in like the processing or what alerts would hit or something? That just seems like a huge drop and not consistent with prior months, I don't think.
It is not. I was trying to find out more data on that information. I just could not find why they didn't have as many.
Okay.
Yeah, I don't have a good answer.
Well, yeah, and it's kind of across the board, right? Like there was just hardly any overrides, which is just is odd. So
yeah.
Okay. Thank you.
Mm-hmm. And then next page is my last page here, and this is just the cost savings report from the ProDER. So these are medications that are not dispensed because were due to the ProDER alerts. So for July, we had 11 different alerts, 418 total prescriptions that were not dispensed. That is over $98,000 in cost savings. For August, 6 different types of alerts, 68 prescriptions that were not dispensed. So that's over $13,000 in cost savings. And then lastly, for September, we had 7 different types of alert, 142 prescriptions that were not dispensed, and that total $26,000 in cost savings. So overall for the quarter, it's $138,492 in cost savings to the state. Any questions?
Doesn't feel like there's a nope. Make sure nobody has them looking for their mute button. Thank you, Lan. Was that the end of it? I want to make sure I'm not jumping ahead.
That is it. Thank you.
All right. Thank you very much. So after prospective DUR, we discuss retrospective DUR, and I'll turn it over to Dave Engen.
All right. Thank you, Roger. So we're starting here on page 34. And just a reminder, we're looking at Q4 data, so I'll try to hit the high points of this report. Again, this first section, it highlights our ongoing initiatives, in this case, the change forms, and it's pretty steady overall. It's slight drop off in decibel vaccine opportunities, but we know the price differential gap, it closes the corresponding cumulative savings. So that amount will drop as well. So we'll keep an eye on this, and we'll reevaluate these trends over the next quarter or two, and see if there's it's still reasonable opportunity. But it looks like overall, at least, roughly a third of the prescribers who are contacted by fax do end up changing to more cost-effective prescription products. So once again, we'll be looking for more opportunities over these next quarters. So on page 35, you'll see it's our Retrodur dose consolidation. It's holding steady compared to last quarter. Not a ton of savings, but still a high proportion of prescribers are taking action with the faxes. So that's positive. I just want to remind you, we also have dose consolidation messaging going on at point of sale right now, and that's not captured here. So just a reminder for that. We can look at the next page, page 36. This shows the expert consult referrals for long-term antipsychotic use in children. And there's a handful, as you can see there, that are flagged as high risk, and the prescribers get a referral to OPK for follow-up. So that's remaining steady as well. And the low number of high risk identified is actually a good thing after the screening process is done. So let's go ahead and look at the next page. So here we see 59 prescribers receive non-adherence messaging regarding high-risk patients who are on stable antipsychotic therapy. Then suddenly appear to stop filling their medication. So they're notified, and we look and we're seeing about half the patients end up with a claim for the antipsychotic in the next 90 days after the prescriber is notified. So getting the message out and trying to help ensure kind of a safety net for those patients. And we'll look at the next page on 38. These are profile reviews. Of course, those first 4 review categories, they're for foster care kids. We also conduct different high-risk patient profile reviews to screen for appropriate drug therapy. Fair amount of lettering is going out to the prescribers with different suggestions to improve treatment. You can see the numbers there. Each of these categories have their own unique criteria that are associated with them, and they'll flag different patients. So patients, they're excluded if they've been reviewed recently. So prescribers don't get overwhelmed or confused with different letters for the same patient. So various numbers holding steady there. And then if we look on the last, or I should say, well, the next page, these are safety initiatives. Once again, these are follow-up letters to the prescriber. It could be after denied claims or those patients on dangerous drug combos. The prescribers are notified, and typically we've been finding about 100 or so prescribers are still, for instance, writing for concerning opioid sedative combos. So we get a message out to them, and then we track over the next 90 days what's going on with that. You can see the other categories that we have. It's follow-up on antipsychotic denials, oncology denials, and just providing a safety net for the patients. Kind of interesting. Look at the antipsychotic denials. That's dropped off pretty significantly for the fourth quarter. Hoping that's because the consolidation, messaging is working. So that's an interesting drop off there, but it can be looked at, I think, as a positive. The last page is our it's the TCAs in kids. You see the number of patients that are denied a TCA for age restrictions, then their provider never requested a PA for an alternative. So we let prescribers know their options. And so not a lot of activity there, but a drop off from before. But again, that can be looked at as a good thing. So, really, once again, I wanted to extend our thanks and how we appreciate your input as a committee, and really hoping to build on some more great ideas. So any feedback that you have on opportunities that either you're seeing or that you're curious about for 2023, we're open to those suggestions. And so if you have any questions with that.
Oh, hey, this is Kat Livingston. I have a question about naloxone. So is the only essentially best practice alert that we're providing around naloxone is with the combination opioid sedatives and not for other reasons?
Are you talking when we review the profiles, or sorry, are you asking what initiatives are we getting the word out for naloxone use?
Yes, the letter is what I'm thinking of.
Yeah, I think we have different ways of handling that. We do. It is a part of the when we screen for high-risk patients for opioids. That is a component of that, but yeah, it can pop up in the polypharmacy reviews. There's a lot of different ways that it can be caught. So the message is getting out, but it would be interesting to track, what kind of uptick, if that's making any kind of difference in the amount of naloxone claims. So not investigated that.
And Kat, that's also required as part of our long-acting opioid criteria. So it's part of some criteria as well to make sure that it's being prescribed.
Dave, hi, this is Mark Helm. I had a question on the antipsychotic Retrodur. Basically, half of the people who are identified as being having stopped their medications get restarted on their medications again, which I think is pretty useful. I didn't know if you had any feedback from any of the providers who are getting letters or any other kinds of outcomes related things. And that's been in place, I think, for a little bit more than a year now. But I didn't know if you were hearing any feedback from any of the psychiatric prescribers, or if there was any other work that was going to look and see what happens with the people who fall away. Do they go on to get restarted on something different at some time later? Or are they falling into different systems, or do you have any sense of that?
Yeah, that's a great question.
A question for a grad student to answer, actually.
Yeah, well, we don't in those forms. There's not a place on there necessarily for them to respond as far as feedback. We haven't to my knowledge had phone calls or other anecdotal evidence that of positive things that are going on as far as whether or not this is helping or if other mechanisms could be employed. But I do, I don't know if it's, you're part of the MCAG group. It would definitely be, something that we would welcome feedback if there's any ways that we can, improve or be more effective in the messaging. For instance, we do keep track of whether or not, there's at least claims for a different antipsychotic, and it didn't appear, at least the data that we had so far, that for Q4 we didn't have any information on that. But yeah, it looks like about half or so, and are getting the claims filled again, and but we would welcome feedback or mechanisms to get that feedback. If there are suggestions to improve that number. We haven't looked into follow-up for those folks, but we definitely could maybe pull some reports on whether or not those ones that don't reply, if maybe another message is warranted, or maybe even like that. Yeah.
Just a follow-up question to that. So are claims for the physician administered drug, like the long-acting antipsychotics, would those be captured here as well?
I'm not sure if the long-acting ones are covered in this report or not.
Is that
Sarah
that
might
would
have information on that?
Okay, that would be, I mean, that would make sense, just looking at least our psychiatrist prescribing practices. Oftentimes we're trying to transition people to more long-acting, so it wouldn't surprise me that they were not necessarily filling the same thing that they'd always been on, because we've switched them to the long-acting antipsychotics. So I'm wondering if that would explain, at least in part, the other half. I mean, I'm sure there's other things in there, but it'd be interesting to know if the long-acting injectables were included in this data.
Yeah, that's a great point.
That's a great question. I thought you were first asking if it was part of the monitoring to see if there was adherence, but because those could be billed as a professional claim, we might see a delay, and so it might be confused for lack of adherence. But your question is about transitions, which good observation, is something we can try to observe.
Okay. Yeah. So that would be, I mean, just as a way to explain maybe some of those folks that seem to not have restarted, maybe they've actually just restarted the long-acting injectables and we're not capturing those.
Great point. We'll look into that. Appreciate the questions. Well, if there's not anything else, I'll turn it back to Rob.
Tim, did you have a question?
Yeah, I was just trying to, back when we were talking about Narcan, I was trying to figure out what the definition of high risk for the opioid use was for the Narcan DUR, but you guys kind of discussed it.
Yeah, Dave, about the morphine equivalence, if it's a 50 or 90, or it's a combination of a sedative, or what kind of bakes into that definition of who we've identified as high risk?
I don't think we've dropped it to 50 yet. To my knowledge, we've kept it at 90. But that would be something to think about as we're, trying to get the message out and highlight the importance.
Appreciate the question, Tim. Makes us look at this and see if there's other parameters or opportunities to identify other members that might benefit. So appreciate that.
Hey, Roger,
any other questions? Yeah, for Dave?
just a follow up to Tim's question, would it be possible to do point of sale messaging at 50? You know, so I know in Epic, for example, we get a pop-up if you're trying to order something that exceeds the 50 MEDs to remind you about ordering naloxone. That's relatively new for us and isn't always working exactly the way we expect it to. But I'm wondering whether or not there could be point of sale messaging about naloxone as well, if there isn't already.
Anything is possible, and I think that we can definitely discuss looking into building something like that. I mean, we do have the capability of point of sale messaging. It's just it's a question of yeah, it would be something to discuss with Gainwell and our analysts as well to figure out how to make that happen. Definitely a good suggestion to get the message out for increase naloxone take up.
Naloxone is my latest, like, what I want to call it, but it's getting more naloxone into people's hands is sort of something that I'm engaged and interested in. And so to me, it seems like if we could do point of sale messaging, because naloxone is something that the pharmacist at the time of dispensing could prescribe, it seems like that may be another place to maybe close those gaps. So it would be great if it were something that we could maybe do.
A great recommendation for us to explore. Appreciate that. We'd have to think what our capability is for the messaging and then to be discreet so it wasn't just noise to the pharmacies, that it would be an opportunity that they don't already have a naloxone. It's the right dose and the right message at the right time. So certainly something for us to take away. I don't know if anybody else on my team or Lan, if you have any questions about that concept or input.
No, but it's something that we can definitely look for or explore more.
Yeah, thanks, Stacy. Last call. Any other questions or observations or thoughts to share with questions for Dave or thoughts for the team to explore? Well, we always welcome those. So as you review these reports, you can shoot us emails. We'll share it amongst the team and then try to bring back initiatives. So in addition to the DUR activities, education is a part of requirements for the state. And one of the ways that we accomplish this is with our newsletters. And we have the Oregon State Drug Review, and Kathy Centena is our editor. So I'll turn it over to Kathy.
Great, thanks, Roger. These start on page 41 in your packet if you want to follow along. And today we'll be recapping 2 newsletters that were published earlier this year. The first one was actually published in April and was titled Asthma Guidance Update with a focus on changes for managing patients with mild asthma. And it highlights the recommended use of single maintenance therapy, or SMART, also referred to maintenance reliever therapy. I hear a little feedback. Can you guys hear me okay?
Yep, hear you loud and clear. I hear the feedback as well. I'm not sure where that's from, but we hear you clear. Thank you.
Okay, fantastic. So again, this regimen is also referred to as MART, which is incorporates the use of a single inhaler as maintenance and reliever therapy in patients with mild asthma, as well as in those with persistent asthma. And we'll actually be touching on this later as well. And then the second newsletter was published in May, and it focuses on population trends in the use of migraine preventative treatment. And this newsletter discusses the evidence for the use of different preventative treatments for migraines and the evidence that supports them, and the results of a drug use evaluation that analyzed the use of guideline recommended migraine preventative therapy in our own Oregon Medicaid fee-for-service population. So again, like Dave had mentioned, we really appreciate all the input from the committee and the feedback that they give us for the newsletters as well, including the authors of the newsletters that help to provide this important provider education. So at this time, are there any thoughts on newsletters going forward that you think would be of value? You can always email us with those as well, or if you think of them as the meeting goes along, we're always open to hearing those suggestions. And then as a reminder, you can also sign up on the website to receive the newsletters electronically, as well as check it. Encourage you to check out our new newsletter just posted yesterday on hormone replacement therapy.
Great, Kathy, appreciate it. Again, any questions or any ideas for newsletters this moment? Okay, hearing none. We're always welcoming those. So with that, we'll turn it over to the next section. Direct your attention to page 48. Actually, was that both newsletters? Okay, page 48 in the packet. We have a polypharmacy drug utilization evaluation, and we'll turn it back over to Dave.
All right, thank you, Roger. So yeah, today we'll be looking at the findings of the DUA that was performed regarding duplicate drug therapy. Next slide, please. So currently we review drug therapy for fee-for-service patients as part of our polypharmacy program and look for opportunities to improve care. One of the areas of focus when we assess appropriate drug therapy is therapeutic drug duplication. Next slide, please. Oh, in this DUE, really want to know how many fee-for-service patients have been prescribed routine or chronic duplicate drug therapy. How often was duplicate therapy prescribed by more than one provider and dispensed by more than one pharmacy? And what's the impact on healthcare resources? So we chose, the next slide, please. We chose a number of drug classes that from the literature appear to be problematic for duplicate therapy. Drugs that had a similar mechanism were defined based on First Data Bank's description of specific therapeutic classes. So you have the different examples up there that we looked at. So just a little bit about the methods that we used. We've looked over a 1-year time frame, and we included continuously eligible fee-for-service and CCO patients with paid fee-for-service claims for drugs in those particular drug classes. And we had two groups, duplicate therapy group, and then we had a monotherapy group that served as essentially a comparator. And so duplicate therapy, it could represent 2 or more claims from the same therapeutic class, for example, 2 ACE inhibitors, or from different therapeutic classes, but similar mechanisms, so like ACE inhibitors and an ARB. And chronic therapy meant 90 days of continuous use. And we excluded patients with TPL or other insurance for this review. Let's look at the results. So at baseline, there are almost 63,000 total patients on these particular chronic drug therapies, but only 816 cases of duplicate drug therapy. So essentially that represented 1.3%. When we started to break it down, for instance, by American Indian, Alaska Native affiliation versus not, we saw a slightly higher duplicate therapy rate, but it was 1.7 versus 0.3, so still pretty low for both groups. Next slide, please. So it turns out the skeletal muscle relaxants had the highest rates of duplicate therapy of all the classes reviewed, with 8.5%. But really, for the year, there were only 117 patients in all fee-for-service with chronic use for these agents. that kind of puts it in perspective. So still overall relatively low. Let's get the next slide. So for patients with duplicate therapy, over 40% turns out were written by 2 or more prescribers, compared to about 23% if you're looking at the monotherapy group. And then most of the patients with duplicate therapy filled their prescriptions at a single pharmacy. However, when you compare it to monotherapy, it appears that the duplicate therapy group actually more commonly filled at multiple pharmacies, 18 versus 13%. But in general, looking at duplicate therapy patients, they were filling at actually a single pharmacy. Let's look at the next. So lastly, we looked at mean healthcare costs, and it appears that patients with the chronic duplicate therapy had anywhere from 1.5 to 2 times the mean costs for healthcare utilization in each of those major categories compared to monotherapy. Now, as with all DUEs, there's a number of limitations. We'll look at those on the next page. There were several, in fact. Just wanted to point out, first, they're pre-selected categories of drugs, so there may be other classes of interest, more or less duplicate therapy. We're not sure at this point. But the claims history, of course, it can be incomplete due to the exclusions of TPL claims or cash pay. And then just, as you know, medical claims data may be delayed, sometimes up to 6 months. So that could have been something that clouded the data a little bit. If a prescriber was performing, say, a dose titration or maybe a mid-range dose in between 2 typical solid dosage forms, it might have been interpreted as duplicate therapy when it might not have been. So that's something that could potentially be a confounder. And then lastly, was to point out, tribal claims have what's called an error rate or an all-inclusive rate for each claim. And this higher reimbursement rate could have skewed pharmacy costs a bit, and then the duplicate therapy group. I'm not sure if and to what extent, but it's a possibility. So based on the data from the DUE, we're not recommending any policy changes at this time, but it was an interesting endeavor, and we got some good information out of it for future ideas. So I didn't know if you had any other questions on this. Thank you. Turn it back to you, Roger.
Any questions? Okay, no questions for Dave. Well, thank you. All right, if you're following along in the packet, we're going to direct your attention to page 64. And I wanted to recognize 2 members of the OHA that have joined us for this conversation. Let them introduce themselves as well. I made you co-hosts. There are Jessica and Liz. Are you able to unmute your lines?
Yes.
Yes.
There we go. Hi.
Fantastic.
Hello,
We really
everyone.
appreciate you joining us. If you want to briefly introduce yourselves, and then we'll get into your information you're sharing.
Absolutely. Thank you so much. I'm Jessica Ickes. I am the EPSDT Children's Policy Analyst with the Medicaid Policy Unit at OHA. Slight side note, it's fun to see OSU up there. I am a 2nd-generation graduate from OSU, so.
Go Beavs.
It's a good day to be a Beaver.
All right. And hi, everyone. I'm Liz Stewart. I am a project manager in the Office of Health Policy in OHA's Health Policy and Analytics Division. And I am the project manager for the expansion of our EPSDT benefit, early and periodic screening, diagnostic, and treatment. It's a mouthful, but we will be explaining it.
We didn't come up with that.
We didn't. That's our disclaimer. I think we can go ahead and move into the first slide.
All right. So we live in the land of EPSDT, but not everybody else does. So that is the federal acronym for early and periodic screening, diagnostic, and treatment. It is the benefit that provides comprehensive and preventative healthcare services for children under age 21 who are enrolled in Medicaid. States are required to provide comprehensive services and furnish all Medicaid coverable, appropriate, and medically necessary services needed to correct and ameliorate health conditions based on certain federal guidelines. A large difference between the adult benefit and the children and youth benefit is this term ameliorate. We do not have to cure a condition. We do have to assist, help, and lessen a condition. So that's probably one of the biggest differences. In Oregon, the EPSDT constitutes the child and youth benefit within the Oregon Health Plan. And listed there is our EPSDT website. You'll see it again. Thank you. Next slide. So who qualifies for EPSDT? OHP members under the age of 21. So on your 21st birthday, you would transition to adult coverage. And in the future, children and youth with special healthcare needs, known as SHIN, will be eligible until their 26th birthday. That expansion is not going to be implemented until 2024. And this was approved by the federal government as part of Oregon's 22-27 Medicaid 1115 waiver.
And I would just note the timeline is still a bit TBD for that expansion. So 2024 is anticipated, whether that's Jan 1, 2024 remains to be seen. And we will provide updates when we know more. Next slide.
Next slide. There's a myth out there that Oregon doesn't do EPSDT. In Oregon, EPSDT constitutes the Oregon Health Plan plus benefit for children under the age of 21 within the Oregon Health Plan. And most EPSDT services have been provided in Oregon for many years, just may not have been under the name of EPSDT.
Next slide.
You want to take this?
Yeah. So the however part, and part of the reason that myth has been out there and why we're here today is because one piece of the EPSDT benefit was waived for Oregon, and no other state actually had a waiver around EPSDT. So this was within our 2017 to 2022 1115 Medicaid waiver and the prior waivers as well. The bolded language there is exactly what was in those waivers. I'm going to give you the translation of that, which is the second bullet. So what it meant was that Oregon did not cover specifically treatment services. So only the T part of EPSDT, and specifically it did not cover treatment services that were below the line on the prioritized list. And that applied to kids between the ages of 1 and 21. So that waiver never applied to children under the age of 1. Next slide. And so what is actually changing is that that waiver is going away effective January 1. So through the public comment process around the Medicaid waiver, so that was in throughout 2021, in the waiver application process, OHA received a lot of great feedback from the community and from advocates and families, which led to a decision to not seek renewal of the waiver regarding EPSDT. So effective January 1, no EPSDT requirements will be waived in Oregon. And we usually make a note here that we did, in negotiation with CMS, ask if we could have a January 1, 2024 start date, and they said no. So we have been on a very tight timeline to stand this additional, this expansion up. But ultimately what this means is that effective January 1, under EPSDT, Oregon will cover, OHP will cover any medically necessary and medically appropriate services for enrolled children until their 21st birthday, regardless of the location of the diagnosis on the prioritized list, whether it's a non-pairing service or a non-covered ancillary service, and regardless of whether it's actually covered under the state plan.
So we have been working to update both CCOs and OHA with guidance and the importance of the reviews for medical necessity and medical appropriateness of previously non-covered services that must occur prior to a denial of coverage. Also, that regardless of the prioritized list, CCOs and OHA must cover any medically necessary and medically appropriate service for enrolled children and youth until their 21st birthday. And we have been working with our partners in pharmacy, and thank you very much for your assistance and your work on this. It has been great. For the pharmaceutical reviews, in order to be in compliance by January 1, as you can see on these slide, that there is some information that has been added, and using this information will get to the necessary documentation needed to do the individual reviews for EPSDT on the pharmacy claims.
All right, I can talk through this one. So we've mentioned the individual reviews, and I'll talk through all the specifics here, but ultimately, under EPSDT, the full implementation after January 1st, CCOs and OHA must either A, approve any of those historically non-covered services for children and youth, or and if they're not just being approved, then the denial must come after an individual review for medical necessity and medical appropriateness. So on their table, you see that CCOs and OHA cannot deny a service or claim solely because it's below the funding line, non-pairing, or a historically non-covered ancillary service. This does include automatic denial by claims processing systems of services that historically have not been covered for this population. So for example, on the fee-for-service side, OHA, we are having to update MMIS to make sure that those claims don't automatically deny just because they appear below the line. CCOs and OHA can, and this is an important caveat, we can deny a claim without first doing that individual review for medical necessity and medical appropriateness in the cases of what is generally called like an unclean claim. So where something was actually entered in error. So incorrectly entered factual information, those can obviously be denied without having to do a review based on the child's needs. We also can deny a service or claim if it is not medically necessary, medically appropriate, or dentally appropriate for a dental service, and that has to be based on an individual review of clinical documentation for the child or youth. We can, as I mentioned, choose to automatically approve previously not covered services without a review for medical necessity. And we can use the prioritized list as a guidance tool, but it cannot be used as the basis for a denial. Next slide.
So what does this mean for the prioritized list under EPSDT? So CCOs and OHA must cover all medically necessary and appropriate or dentally appropriate in the case of a dental service for children and youth under the age of 21. The HERC continues to review clinical evidence and update the prioritized list. The list, as stated previously, remains a guidance tool for identifying services that may require documentation to establish medical necessity and medical appropriateness. or dentally appropriateness for members under 21. And the HERC has recently completed a review of historically non-covered services with the unique needs of children and youth in mind to minimize the need for individual reviews prior to approval of services. And that's been a lot of work, and it's great that they've been able to complete that. Next slide. So
I'm sorry, this is Dr. Helm.
Yeah.
Don't mean to interrupt, but
no, by all means.
I wonder if you can provide us with information on where one might be able to find that the results of the review of the things that were historically not covered and the Darnall covered.
That is a great question, because we've been asked that by multiple people, internally and externally. Yep. And so we are working with our partners who staff the HERC to try and produce that. It's not as straightforward to put that document together as one might think. So, but we are working on being able to provide that to show what that review has looked like and what are those things that have sort of moved above the line as part of that review.
Is there a communication process that's involved in that? Will you be engaging Oregon Pediatric Society or OMA?
We'll be making sure that it gets out. We actually haven't quite gotten into what that process will look like, but we will make sure that we are able to disseminate that, and we can make sure that that gets back to this group as well.
Thanks.
Yep.
Thanks
Absolutely.
for the question.
And we're happy to answer questions as we present. So don't worry about that. So prior authorizations, they must be conducted on a case-by-case basis, evaluating each child's needs individually. Procedures may not delay delivery of needed treatment services and must be consistent with the preventative intent of EPSDT. And PAs may not be required for any EPSDT screening services. Next slide.
I think we can probably, in the interest of time, kind of skip over these next couple of slides unless folks are really interested, but we do have a couple of slides in here that talk a little bit to kind of the justification and sort of legal background for compliance with the federal requirements. And some of the wording from CMS and DOJ is in there if anyone wants to check that out.
So these requirements, again, are effective January 1, 2023, exactly 1 month from today. And knowing that this is a huge lift for both OHA, CCOs, everybody involved, that we are not expecting full implementation until the end of Q1 of 2023. So these are going into effect January 1, but even our systems like MMIS, they need to be updated, and those won't be available until February, March. So we are understanding that we will not be monitoring and we will not be requiring full compliance until the end of Q1. And also noting that even though it's a big lift to get to January 1st, most of our work is going to happen to make Oregon have the robust program that we want, is going to happen starting in January and going forward.
And I think an important note there too is that we definitely look to all of our partners, to you all, the CCOs, providers, families, members, anyone impacted by this change to help us inform quality improvement as we go. And we are working on setting up sort of structures for feedback and as well as making sure that everybody knows where to reach us with questions and concerns. So we definitely want to know about questions, gaps, hurdles along the way. We know there will be a lot of work to do after the go live date. So next slide, please. So we are putting out guidance, and actually these slides are out of date as of about 2 hours ago because our guidance for healthcare providers actually went live this morning. It'll be going out in our Provider Matters newsletter tomorrow, but it is posted on our website. So I'll actually post a link in the chat There's a memo that is a good overview of the policy change with a link to our provider guidance. We have a guidance document went out to CCOs a couple of weeks ago. That's available on our webpage, which is listed there on the slide. And then we are also working on an additional sort of amendment to guidance to CCOs and OHA that'll be out before the end of the year, specifically around which types of EPSDT services can have prior authorization applied to them. That's been a question we've gotten multiple times and needed to do a little bit of homework on. We know that obviously screening services can't have that, but in terms of things that were previously not covered, but now are potentially coverable, where can we apply prior authorization or not? So that will be coming as well. Next slide. We have a web page. We've put it on multiple slides. It's there. All of our guidance documents, communication materials are there. We also now have a member fact sheet for OHP members that is posted. It's currently posted in English. Translations into the additional 12 top spoken languages by OHP members is coming. And those will all be available there on that web page as soon as we have them. So, and any additional updates we have will also be there. Next page, next slide. The rest of these, I think we can probably skip over. I'd probably go to the last slide. We have a few reference slides in here that have some resources as well as the sort of the governing rules and CFRs of EPSDT. On this slide is our email address that will get you to me and Jessica. And we would encourage, if you have questions or want to share this with any other partners, this would be the email address to use for any sort of questions, clarifications, concerns that might come up. And I think that's it. I'm going to drop that link to the memo into the chat so that everyone can access that. It's also, if you go to our webpage, it should be, it's pretty much front and center. Question.
That was great, Jessica and Liz. Questions for them? All right, we have additional information, kind of how we are taking this information and incorporating it for the fee-for-service program and PA criteria. Again, in the packet, that's page 64. Jessica and Liz, I don't know if you have to drop off or if you're available to stick around while we do have this presentation, and in case additional questions come up that you might be able to address, we appreciate that. So we're going to turn it over to Sarah.
Yes, thank you, Roger. And thanks, Jessica and Liz, for setting the stage for this. So you've heard all about EPSDT and how it's going to affect some of the coverage levels. And we've been evaluating internally, trying to identify how to best operationalize this on the pharmacy side. And so Sarah, if you can go to page 64 to see our recommendations. What we've landed on how best to operationalize this is to update all of the prior authorization criteria to support the individualized review based on medical appropriateness and medical necessity for members who do meet the EPSDT age ranges. And then in the absence of any more specific criteria already approved by P&T, we have some standard definitions for the medical appropriateness and medical necessity that we'd like to insert into the prior authorizations. And those include FDA approved or compendia supported indications, trial and failure or contraindication or intolerance of other products that are preferred in the same classes if that's available, and then documentation that the disease is of sufficient severity that it does impact the patient's health and their ability to learn, grow, and develop as dictated by EPSDT. And so if you go to the appendix on the next page, to Mark, to your question, what we did internally is we went through our usage data, our prior authorization requests, the denials, and the prioritized list kind of line by line and PA by PA to try to identify which classes that this was going to affect the most. And so Appendix 1 is not the comprehensive list. We do want to roll this out to everything, but the ones in this appendix are the classes where we think it's going to have the most effect for drugs that were being rejected or denied based on funding level alone and not
not some other kind of clinical or safety criteria. And so just to go through two of them, for example, acne, right now it's funded for severe disease such as cystic acne or acne fulminans, and mild and moderate disease is not funded. But under EPSDT, we've made changes to allow for the individual case review. And then if you look at question 3 with the funding question, there's a bifurcation for age to identify those who would qualify for EPSDT. And then on the next slide, asking the questions of the documentation of is it affecting them in other ways as far as socialization, mental health, ways that affect their ability to live, function, and grow and develop. And then finally, because this is a class with other products that are preferred, have they tried other preferred products before going to a non-preferred within this one? And the next PA is for non-funded, non-preferred drug products. And you can see it's similar language we've inserted for the case-by-case review, the bifurcation based off of the age, and then just asking for the documentation that it is of true medical necessity and that other alternatives have been tried if they're applicable. And so those are all in this appendix. I'm not going to go through the rest of them because it's very similar, but these were the changes that we were recommending. And we think with acne, non-preferred, the NSAIDs, the tetracyclines, all of those in Appendix 1, and the changes we made to the nasal steroids in the last meeting, that will get the lion's share of these prescriptions until we can operationalize it everywhere. Kat, I see your hand up.
Yeah, I just, I'm noticing that language where it says EG, quality of life, function, growth, development, ability to participate in school. So that EG language is different than what's in the statement of intent. And I'm just wondering, is there an intent to match those up? Is this kind of the new language that everybody's supposed to be adopting, or what are the thoughts about this being different than what was in the prioritized list language?
I think that the list may have changed some of the verbiage along the way as these have been updated. I don't think I recognized that they were different or that ours was different than the most. There are different versions of it as this has been developing, but we can ensure that it's the same. I guess would be my answer. There we go.
Thank you. I don't know how that happened, but I appreciate you catching it.
Yeah, Kat, did I answer your question? We'll check to make sure that the language matches if it's off by a few words.
And I can jump in there too a little bit. There's two different kind of spots where this is addressed. One is in the definition of medical necessity that's in OAR, and then the prioritized list also does have a statement of intent about growth, development, and participation in school. And the language that is in here now is intended to match the definition of medical necessity, since that's what we have to use to review requests under EPSDT based on this medically necessary definition.
Thank you, Sarah.
Okay, so they will be different, and that's expected because the statement of intent isn't necessarily addressing medical necessity, but this is. Is that correct?
That's the intent, yes.
And the way this is designed as well is how Sarah was designing this bifurcation when it asked the questions about EPSDT, this medical appropriateness and necessity being different parts of the OAR will also result in different responses that come out from Gainwell when we have a EOB to the pharmacy, or if we have a review of this, so that should we not have additional information sufficient to know if it is medically necessary, a denial of the prior authorization would have language supporting the provider providing that additional information, so it could be on a case-by-case basis reviewed to see if it is medically necessary. So it helps us out in the language that goes into the lettering that goes to providers as well. Any additional questions for Sarah or our guests from the OHA? All right, so we do have recommendations in front of the committee. And we're going to be recommending that we update the PA criteria to support this individualized review. Again, we have examples in the packet, but we'll be applying this more broadly to other criteria. And we'll include these standard definitions. So we do need to take action. Do we have a motion to approve?
I would move to approve.
Seconded.
All those in favor?
Aye.
Aye.
Anyone opposed? And abstain? Thank you.
Fantastic. Thank you, everybody. Again, if additional questions come up, appreciate that. And this is something that we'll continue to build upon in future meetings and as we address criteria. And I think as the committee is aware, we've done this in other ways as well, like the nasal allergy inhalers by making some products available without PA. And so it's another way to make things available. So again, Jessica and Liz, thank you very much. We'll continue on in the packet. If you're following along, we're turning to page 94 and we'll turn it over to Sarah Servid.
Thank you. And I am going to briefly be discussing a sedative PA update. And just as a reminder, we just recently reviewed this evidence for sedatives at the P&T August committee meeting. Currently, all of these sedatives, which are most commonly used for insomnia, do require prior authorization. The exception being melatonin, which is available for kids less than 18 years of age without PA. PA criteria do look for concurrent sedating drugs and require documentation of a relevant comorbid condition, since insomnia has historically been unfunded below the funding line on the prioritized list in order to get a PA approved for sedatives. The Health Evidence Review Commission did recently look at this class of drugs and insomnia as a topic in general and recommended that insomnia be moved to a funded line on the prioritized list starting in January. They have a new guideline note which addresses use of sedative hypnotics, and they recommended a limit of 1 month of treatment per year in patients who are currently participating or have previously failed to have benefit with cognitive behavioral therapy. Cognitive behavioral therapy is first-line recommended treatment for insomnia and historically has not been covered because of the funding line on the prioritized list. So it will, starting January 1, it will become available as a funded treatment option. And so this PA update essentially aligns with the HOOK coverage guidance. And you can see the changes, recommended changes to the PA criteria here. We'll be keeping the initial questions, which essentially screen for concomitant sedating therapy and dose, for example, for zolpidem. And these changes essentially add step therapy for cognitive behavioral therapy. Have they tried or have failed to have benefit with CBT? And then also limiting sedative treatment to that 30 days. I'm also recommending addition of renewal criteria that is essentially in line with some of the things that criteria that we have for benzodiazepines. Since these drugs can be habit forming and have withdrawal effects, the renewal criteria is essentially intended to serve as a safety kind of mechanism for patients that are unable to taper off the medication if they've been on it long-term already. So essentially asking if the request is for a taper, and if not, asking the provider to provide documentation that the ongoing benefits of the therapy outweigh the risks of the therapy. And so the overall recommendation is to update PA criteria to limit sedative use to 30 days and then also incorporating that use of cognitive behavioral therapy as a first-line treatment for insomnia. And I'd be happy to take questions.
Sarah, is there going to be, so I imagine that CBT isn't available everywhere. Are there, what if the patient can access CBT?
Yeah, that's a good thought. And we have incorporated that into some of our other criteria. So in question 12, we could add, you know, are they currently engaged in failed to benefit or have inability to access CBT?
Yeah, I mean, I think it would be great. I think, you know, the study shows CBT is the way to go for sure, but I just worry about folks who can't access it and maybe have otherwise relied on things that are not saying not great, but it's what they've been using forever. So I like the slow taper plan. That definitely works, but I wonder what everybody else thinks about maybe adding a line about being unable to access CBT.
I just want to, Kat, go ahead.
Oh, the VA has a really nice app that has CBTI, cognitive behavioral therapy for insomnia. That's free and available and super evidence-based. So for those who are able to work with an app, CBTI is available that way.
Yeah, it's called CBTI Coach.
That was actually to the point that I was going to make, that even other approaches beyond CBTI or cognitive behavioral therapy that's done in person can be very helpful and useful. So there are lots of other approaches that can be used that people don't necessarily have barriers to because they're available as an app. You can even listen to a guy read really boring and slow stories and lulls you to sleep because he's so intensely boring.
Yeah, but there's still, I mean, just looking at our patient population, we have a significant number of folks who don't have a smartphone. And so apps are not necessarily going to work for them. I'm not saying this is everywhere, but I'm guessing if, you know, we've got patients within our system that those things aren't an option for, then it definitely exists across the state. I absolutely think we should include all of those, and you know, maybe that could be part of our educational outreach. But I also think we need to realize that there still are people who are not going to be able to access under these mechanisms.
And also the data for the effectiveness of CBTI apps is, you know, a decade behind the data on the efficacy of CBTI done with a coach or a therapist. So, I mean, you know, your average app, you know, produced by the VA is one thing, but, you know, an app produced by someone who's out there trying to make money, you know, I mean, I don't know that, you know, app-based sleep treatments, you know, it's a pretty, an extremely variable group. And so I don't know that, you know, including that in any sort of a recommendation without being extremely explicit in what sorts of apps would necessarily be evidence-based. And I also agree in CBTI being slightly different than CBT, but you know, not necessarily everybody who even does CBT is comfortable, you know, focusing on sleep or has the, you know, the experience treating insomnia specifically. But I agree with the point that CBT is not necessarily available everywhere. And certainly, even if it were available everywhere, you know, your average therapist has 30, 40 patients at a time on their panel. And so the number of people we have getting sleep aids, the vast majority of them would not be able to get in to see a therapist, you know, if we referred all of them. So, you know, certainly there are going to be a lot of folks for whom it's not available. So, which I guess is to say, yeah, we should, I mean, including the line that maybe CBT isn't available would be agreeable to me.
I hear that like a motion from Stacy and a second from you. Tim?
Yeah, I was just going to restate what you guys are saying, that to kind of represent the low socioeconomic access group, the rural group where access is an issue, and technology and resources, having it be a hard stop is lean against it. We are talking about long-term therapy with medication, and so there's concerns with that, but we are kind of tied with our with availability and access.
Appreciate that comment.
Yeah, I mean, generally speaking, I prescribe very few sleep aids, certainly very few, even fewer controls. But I mean, if you have a patient with PTSD and I mean severe anxiety and it's, you know, sleep or lose their job, you know, I mean, harm reduction would tell us that there are some folks who are just going to end up being on sleep aids, either, you know, for some short, intermediate, or long period of time, either because they, you know, can't get a therapist or, you know, can't afford a therapist. It's covered under OHP, but you know, it also requires time off, and most therapists, like most of us, are, you know, only see patients during business hours. And so, I mean, there's lots of reasons why a person may not be able to get in to see a therapist, and certainly, you know, economically disadvantaged people are going to be overrepresented, both in terms of people who are more likely to have anxiety and PTSD and depression and other things that cause insomnia, and also because they're less able to access other forms of treatment. You know, medications are well covered, whereas other forms of treatment require more time and energy and money.
I have one question on the definition of long-term treatment of insomnia. With a lot of our medications for insomnia, if it's used daily long-term, there's tolerance and loss of efficacy. But if it's used, you know, periodically, like a number on different days within the week, it still maintains efficacy. So how does this PA criteria define long-term use? Is it like 90 days every day, or what is it?
Yeah, that's a good question. The way it's defined here is based on the definition recommended by HERC, which is more than 30 days of treatment in the year. After that, it'll default to the renewal criteria and require that the provider, you know, document those, you know, benefits versus risks. And I expect this would be where the provider would say, you know, they're using it infrequently, so it still has benefit. And then we could approve it for longer term, up to 3 months is the recommended duration of treatment here.
So there's not necessarily a barrier to starting it if you're dealing with like situational insomnia. You know, someone's dealing with, you know, loss, grief, something like that, then they would have no difficulty getting a couple of weeks supply, right? It only starts to kick in when it's chronic, daily, 90 tablets in 90 days.
Well, all of these sedative hypnotics do require PA upfront to screen, in part for like concomitant opioid use or other sedatives that might result in an additive effect. So they all do require PA, but the initial approval will be for 30 days. Subsequent approvals can be longer.
Is there not a way to look to see concomitant medications that might be problematic just by looking at the point of sale medication history without engaging a prior authorization?
We could certainly look into that. I think there are some mechanisms, but I'd have to do more research to know exactly how they would work.
Mark, I think that was you. Or Russ, are you thinking about like an auto PA process for that initial fill?
That was me. This is Mark. Yes, that's what I was thinking. An automatic process for the initial fill, and if the initial fill is like 15 tablets, and it's supposed to cover them for a month, and I don't think anybody's going to get into serious harm in those situations. We talk about harm reduction. And that may be useful in some situations. I always worry, when is insomnia not really insomnia, right? I'd also be curious or concerned about any scenario where a sleep aid sedative hypnotic was being used in addition to stimulant medication.
Yeah, I've been seeing that more in my practice. That's that raises one's eyebrows when somebody gets a stimulant and also a sleep aid.
So what I'm hearing is maybe a recommendation to look into how we can automate approvals for short-term use, initial short-term use.
That's what I would suggest. If you're talking about like 15 tablets over a 30-day period or a 45-day period or something along those lines, then that shouldn't necessarily be a problem unless there is concomitant use of a stimulant or concomitant use of another medication that might cause a serious side effect complication. So opiates and other benzos and other kinds of issues like that. That's what I would suggest.
We can certainly do more research with that.
Well, don't commit to it until anybody else agrees with me. So.
No, I think if there's a way to practically do it, that definitely makes sense. So I agree with you, Mark.
Yeah, I do too.
I agree.
And I think all of the medications of interest would actually still be within open card or OHA coverage, because they're all in the 7-Eleven category, I think.
Is that? I don't think that's true, is it?
Well, if we're talking about stimulants and we're talking about benzodiazepines and we're talking about opiates and all that.
Yeah. I thought only clonazepam though was the carve out. I thought the other benzos, if they have CCOs, that the CCOs were covering those. I could be wrong though.
CCOs do cover some benzos, and CCOs also cover some stimulants.
Right, and like Adderall, for example, I think we bill through CCO coverage, not open card coverage.
Correct.
Okay. But could you still see it though? Like if it's not being billed, if everything wasn't being billed to open card, but it was still under a CCO, would you still have access to those claims to do some type of auto PA?
Well, they wouldn't be seen, so they wouldn't be a reason to deny a claim. And there is a delay in the encounter data being received by the OHA and then entered into the MMIS, since it's not billed through MMIS. So there can be delays there, but that wouldn't result in a denial because you'd see that concomitant use. It's when we do see the claim that we're hearing develop or explore an opportunity to have an auto approval for a short time supply.
Yes, but to Mark's point, I don't think that we wouldn't necessarily be able to see those exclusion criteria at the time of filling them. So I think we would have to decide that we would be okay with an auto PA for a small amount, regardless of what else they're on, right? Just in terms of being able to operationalize it.
Yeah, we can explore that.
The problem is, I think that OHA can't necessarily see it, but that the pharmacist, the individual pharmacist dispensing the medication, assuming that the patient is using a single pharmacy, should be able to see it.
Right. Yeah, definitely. They should be able to see it, but again, only if they're using the same pharmacy. So, and it should be available on PDMP, but then that becomes, I think that's not an auto PA process. That's a drug use review at the point, you know, at the time the pharmacist is filling it, which already has to happen. So I think that those are two different things that we're talking about though.
Right, we're just talking about editing off the data that we see in the MMIS. Any other questions or recommendations? So the recommendation I'm hearing in front of the committee is the original: update the PA criteria to limit sedative use to 30 days, encourage use of CBT for insomnia, and amend to add language in that question to regarding being unable to access. And still, one of the takeaways for us is to look at and explore education on CBTI, but then also explore options to auto-approve a short-term supply at the point of sale. Did I capture everything?
Yeah, I think so. Yes.
So then we need a motion to approve as amended.
So moved.
Second.
All those in favor?
Aye.
Aye.
Anyone
Aye.
opposed? And abstain? All right, thank you.
Great. Let's do one more class before we take a quick break. So draw your attention to page 100 in the packet, and we'll turn it back over to Dave.
All right, thank you. Yeah, we wanted to take just a little time to discuss some proposed changes to the growth criteria. This update, it's an attempt to align the PA criteria with the current HERC guidance. So to comply with that guidance, it'll require us to make some changes, allow for limited coverage of GH for adults, and also necessitate an individualized review of GH needs in children and adolescents. Let's take a look here. The changes stem from Guideline Note 74. Mostly the use of GH had been restricted to funded diagnoses and generally continued until adult height as determined by bone age. But in January 2023, GH therapy for children and adolescents will not only need to be initiated and continued by pediatric specialists, but may also be reviewed for medical appropriateness on a case-by-case basis. So look on the next slide. Prior to the update as well, there's treatment for isolated deficiency of human growth hormone, so hypopituitarism in adults was not covered. But in January 2023, GH treatment for hypopituitarism may be covered for adults when 3 requirements are met. So need endocrinologist input, and GH deficiency must be confirmed by lab tests or historical evidence of a lack of growth hormone. And third, it can't be used for anti-aging therapy or athletic enhancement. Other GH treatment continues to be covered in adulthood for things such as HIV-associated cachexia and short bowel syndrome. Table 1 it's currently in your packet. It's also part of the PA. It lists the FDA-approved GH agents and their indications, and it's separated by pediatric and adult populations. But let's look at the criteria itself, and I'll quickly highlight the updates based on the new guidance. So when we go to number 1 and 2, there's our standard questions, but number 3 is a new question. We asked the prescriber to state the goals of therapy. So we know what to consider when it comes up for renewal consideration. So that is something new. And number 4, it lists the various indications for GH. And if it's not one of the FDA indications, then have the option to go to number 5. And so you see number 5 allows for the EPSDT assessment, and that's a new question as well. So we have the appropriate language in there for that to be adjudicated. Number 6, it distinguishes new starts from continuation of therapy. And then number 7, it aligns with HERC guidance requirements for pediatric prescribing. So we have appropriate language in there, as we discussed before. Number 8, it parses out the contraindications for patients with Prader-Willi syndrome. And that was also in the old criteria. Number 9 and 10 also align with the new HERC guidance. We've removed the specific bone age assessment questions and allows for coverage if criteria is met. So number 11 and 12 encourages the use of preferred products, and 13 and 14, they help ensure appropriate weight-based prescribing for lonapeg-somatropin according to the package insert. So those aren't new questions either. And then for renewal, 2 through 4, they help assess whether a benefit has been observed. If the goals were to say improve height. But then, number 5 allows for assessment of benefit if there were other therapy goals. And then 6 and 7 encourages the use of preferred products. So based on that, I don't think we have any public comment, but before we get to the recommendations, I just want to see if there were any questions on that criteria.
Quick question on somatotropin. We have preferred agents and whatnot. And the hardest thing I've seen in clinical practice is actually the dose conversion between the agents. And so I'd assume when people come on to Oregon Health Plan, if it's a continuation, they might be on an agent that wasn't preferred. So is there guidance for dose conversion for people that when they're coming onto the health plan?
We don't have guidance in there right now. Of course, there is guidance available, but it tends to be certain products that are used. So I haven't seen a big fluctuation between different products being used. So it hasn't been an issue yet. But yeah, the criteria doesn't have every different type of scenario, but mostly because it hasn't been necessary at this point. It's something that we could look into, especially if it does become an issue. That's a good call out.
I would consider it because in clinical practice, I've seen providers, pharmacists have challenges doing the recommendation of dose conversion between the products based off of the way they're manufactured.
Okay. Well, we can definitely consider that, and then when this should be coming back in the near future again, and so we can have updates at that point to the criteria that would work for the committee. where you recommended that a dose conversion table be added. I don't have that. Not sure the best way to handle that. Well, feel free to jump in. Yeah, my recommendation would be to update the growth hormone prioritization criteria to line up with her coverage guidance and FDA-approved indications, and evaluate costs in the executive session of informed PDL status.
Thanks, Dave. Do we have a motion to approve those recommendations?
Move to approve, Loriger.
Do we have a second?
I'll second.
Thank you, Tim.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Thank you.
Great. Sorry, was there somebody having a comment? Okay, thank you, Dave. We're scheduled to have a break right now. We initially blocked off 15 minutes. We're about 5-6 minutes behind schedule. What's the committee's preference? Would you like a 15-minute break still, or a 10-minute break?
I think 10's probably fine if that's okay with everybody else.
Yeah, 10's fine.
10's good.
All right. I am going to start my timer, put it on the screen, and then pause the recording, but we'll go on break right now and see you back here in about 10 minutes. Thank you. Welcome back. That's fast 10 minutes. For those of you following along in the packet of materials, direct your attention to page 108. We have the drugs for asthma COPD class update. And Kathy Centena, I'll turn it over to you.
Great, thanks, Roger. So today we're going to be looking at some new literature that's been reviewed since the last updates that occurred in October of 2020 and 21, and then in July of 2019. In this class, we have several inhaled therapy classes actually included, the inhaled anticholinergics, long-acting beta agonists, short-acting beta agonists, inhaled corticosteroids, ICS-LABA combinations, and LAMA-LABA combinations. You can find a full list of these therapies listed in Appendix 1, which is on page 127 in your packet. So just quick background and review. So for asthma, we know inhaled treatment is comprised of the quick relief medications that we'll be talking about, short-acting beta agonists, as well as formoterol, and then long-term controller medications such as the ICSs, LABAs, and LAMAs. Asthma treatment is usually initiated in a stepwise manner based on the severity of asthma symptoms. And some newer evidence demonstrates that even people with mild asthma can be at risk of exacerbations, and therefore several guidelines are recommending the use of ICS formoterol as reliever therapy, as well as controller and reliever therapy that they refer to as SMART, single maintenance and reliever therapy, or MART, maintenance and reliever therapy. So we'll be referring to those as we go along. And then for COPD, we know the common treatment and the standard treatment for this disease state are bronchodilators and antimuscarinic drugs such as LABAs and LAMAs. And for patients who require additional therapy, combination therapy is often used in this population, as well as even triple therapy for those patients that have sustained symptoms despite dual therapy. So if we focus on the new evidence, we have two systematic reviews for asthma, and they're both from Cochrane. And the first one looked at this combination fixed dose beta agonist and steroid inhalers for as required or as needed therapy in adults and children with mild asthma. And they did find that this combination, compared to just a FABA alone or a fast-acting beta agonist alone, when these were taken just as needed, that the combination reduced asthma exacerbations requiring steroids. And this was actually the outcome that had the most evidence, high-quality evidence to support this outcome. But it was also shown to decrease hospital admissions or unscheduled healthcare visits, as well as exposure to systemic corticosteroids. When this combination was compared to just ICS alone, they also found that the combination FABA-ICS did demonstrate a reduction in asthma-related hospital admissions or unscheduled healthcare visits. However, this was based on low strength of evidence. The second review looked at regular treatment with formoterol and ICS versus regular treatment with salmeterol and ICS for chronic asthma. And this was really a safety review, systematic review and meta-analysis, and they found that the safety profiles for these two agents were somewhat similar. No major differences found. However, there was insufficient evidence on mortality outcomes. The next systematic review looked at COPD, a new triple formulation done from review done from Cadith. And so this triple inhaler combination consists of budesonide, glycopyrronium, and formoterol. And it found that this single inhaler reduced the rate of moderate to severe COPD exacerbations compared with either glycopyrronium plus formoterol or just the budesonide plus formoterol when it was looked out to 52 weeks. And it also improved FEV1 at 24 weeks compared to those dual therapy combinations. This agent was also reviewed under new formulations. So in your handout, table 13, page 123, it does have the results of those specific studies if you're interested. They also looked, Cadith also looked at changes in quality of life and found that based on the St. George Respiratory Questionnaire, that there really wasn't any significant difference in quality of life. And they concluded that there was insufficient direct evidence comparisons to other triple therapy regimens, but indirect comparisons did suggest similar efficacy and safety to currently available options. The last systematic review is done in COVID patients, and it looked at ICS therapy in those patients with mild COVID treated with an inhaled steroid compared to standard of care, which included antipyretics and antibiotics. If appropriate. And they did find a reduced risk in hospital admissions. So those treated with ICS, incidence of admission or death was 57 per 1,000 people treated with ICS compared to standard of care, which was an incidence of 79 per 1,000 people treated. However, of note, the study was performed before the introduction of the vaccine. So if these results are sustainable in the current environment, that is unknown. So moving on to guidelines, the National Asthma Education Prevention Program Coordinating Committee released new guidance in 2020 for asthma. Some of the changes to the new guidelines include the recommendation of the use of a single inhaler, again, that ICS formoterol combination, both daily and as needed for individuals over the age of 4 with moderate persistent asthma. They also recommend a LAMA for those patients that require, in addition to an ICS, to control symptoms who are over the age of 12 that have uncontrolled persistent asthma that are not able to take or use an ICS-LABA combination inhaler. And then they also recommended the use of a LAMA for those that are not controlled using an ICS-LABA combination inhaler. There's 3 other guidelines we're going to touch on just briefly as well. The next one is the GINA guidelines, so the Global Initiative for Asthma. They updated their guidance in 2022. And what they did is they separated treatment plans into 2 tracks. You can see here track 1 and track 2. Track 2 is the traditional treatment recommendations that we're somewhat accustomed to. So I'll focus on track 1, which is the recommended track if patients can tolerate it and that's an appropriate choice. So if we look at step 1 and step 2 therapy, which is mild asthma, they do recommend that as needed low dose ICS formoterol combination for the as needed therapy or reliever treatment. For step 3 asthma, which is considered moderate, they recommend low dose MART therapy. For step 4, which is considered severe asthma, they do recommend a medium dose MART therapy. And then for step 5, there you can see they recommend that triple therapy with an add-on LAMA if appropriate, and referral to some specialty diagnostics and other asthma pharmacotherapies. And then just briefly reviewing the next guideline, it's the GOLD guideline that was released in 2022 for the management of COPD patients. Not a lot of new things to discuss, just to reiterate that bronchodilators are recommended. They have the most data to support outcomes such as lung function improvement, dyspnea, health status improvement, and reduction in exacerbation for these long-acting products such as LABAs and LAMAs. And then LAMAs have been shown to decrease hospitalization rates as well compared to LABAs. But again, nothing too new in these recommendations. Again, they do recommend ICS therapy as well for appropriate candidates, however, with the caveat that they may increase the risk of pneumonia in patients that have severe COPD. But the triple therapy we know has been effective also in improving lung function, health status, and reducing exacerbation, which is the main goal of COPD treatment. I should note too that they just released their 2023 guidelines just a couple weeks ago. We did post our documents prior to this release, but when reviewing them quickly, it doesn't look like any major changes to the pharmacotherapy recommendations. But of course, those will be highlighted in the next review. And then moving on to the last guideline, this one was done by the U.S. Preventative Service Task Force, and just updated the recommendations for COPD. And it just kind of reiterates what the other guidelines have already stated, such that LABA, LAMA, ICS, or the combination products all reduce the risk of exacerbations in people with moderate COPD, and that tiotropium has also demonstrated a reduction in deterioration in people with moderate COPD, as well as reductions in exacerbations in people with minimal symptoms and moderate airflow obstruction. And they didn't find any major harms, new data for harms with these inhaled therapies, such as mortality risk or things of that nature. So moving on to new indications, we have Breztri there. That's the triple drug combination that we already talked about with the CADTH review. So this agent was reviewed, which was approved for the maintenance treatment of patients with COPD back in July of 2020. It's not indicated for asthma. And again, there's more information on that table 13 if you are interested. The next treatment, the Arminair Respaclick, this was approved for a new formulation, a 30 microgram strength, and this is a lower strength than currently available due to the next bullet point, in which it received an expanded indication in July of 2021 for the use in pediatric patients 4 to 11 years of age for the use as a maintenance treatment for asthma as prophylactic therapy. And then the last therapy is a Trelegy Ellipta. In September of 2022, it's a triple drug combination that received an expanded indication for the treatment of people 18 years and older with asthma. So it is available in a new dosage form as well. It has a higher dose of fluticasone, 200 micrograms, compared to the previous approved dose, which was for COPD patients, which has 100 micrograms of fluticasone, but with the same dose of umeclidinium and vilanterol in both formulations. And then now I'd like to discuss some changes to the PA criteria, and we have several, so I'll try to go through them quickly and feel free to ask questions. These start on page 132 if you want to follow along in your packet. The first one is for the LABAs. We can see there in red that we're recommending to eliminate step therapy. I do want to just remind everyone that this criteria just applies to non-preferred LABA products. So if we look at the next slide, number 1 and 2 are just standard messaging. Number 3 delineates if it's for patients with asthma or active airway disease. we refer them down the table. So number 4 applies to COPD patients. So we ask if the patient has a diagnosis of COPD, mucopurulent chronic bronchitis, or emphysema. And if so, to go ahead and approve this for up to 12 months. The next bullet, number 5, is for asthma patients. And here we're just asking if they have an active prescription for inhaled corticosteroid or an alternate asthma controller medication. And if so, to have it approved. So we're simplifying the criteria to correspond with guidelines. So the next one is for the 2 and 3 drug combination inhaler products. Now this PA does apply to all 2 and 3 drug combination, well, all LAMA, LABA, ICS combination products. So looking at this one, again, number 1 and 2 standard messaging, number 3, again, that delineation between asthma and COPD. So number 4, again, talking about COPD patients. So if they have a diagnosis of COPD, mucopurulent chronic bronchitis, or emphysema, then we ask them in number 5 if it's a request for just a 2 combination product. If so, to go ahead and approve that and discontinue any other maintenance therapies. Number 6 is asking if they are requesting a 3-drug combination product, and if so, basically that they've tried a 2-drug combination product and not succeeded on those. And if so, in number 7, just asking that they stop coverage of those other maintenance therapy products, because we've actually had questions about this, wanting individuals to continue on both, which doesn't align with guideline recommendations. So if they are willing to do that, then go ahead and approve that triple combination of product. Number 8 speaks to asthma patients, and it just asks that they have some sort of active on-demand short-acting beta agonist prescription or ICS formoterol prescription for an as-needed rescue inhaler. And if so, number 9, if they're asking if their request is for Trelegy Ellipta, because that's the only combination product approved for asthma patients. And if so, to approve that for 12 months. Moving on to LABA ICS, the recommendation on this one is actually to retire this criteria, just because to align it with guidelines, the additional recommendation would be to really streamline it and change the criteria quite a bit. So what we would recommend is just to go ahead and retire this. It only applies to non-preferred products. And then those non-preferred products would go through the regular non-preferred general PA requirements for non-preferred products. So it's basically just asks if the patient meets the diagnosis requirements. If you turn the page, if you look, you can see we just, in number 3 and 4, we're just asking if they have asthma or COPD. And then you can see on the next slide, we eliminate all the other requirements is the recommendation currently. So of course we could change it, but that's why we thought it would just be appropriate to try to streamline things and retire this criteria. The last one to talk about is for ICS. Again, this one only applies to non-preferred products. Again, 1, 2, and 3, you've seen before, pretty standard throughout the criteria. Number 4 pertains to COPD patients, as well as those with mucopurulent chronic bronchitis or emphysema. If yes, we ask that they, if they're requesting an ICS, they have an active prescription for some kind of inhaled long-acting bronchodilator as recommended by guidelines. If so, be approved. And then for asthma patients, just asking that they have some kind of active prescription for an on-demand SABA or an alternative rescue medication for acute exacerbations. And if so, it would be approved. So my recommendations for this class are no changes to the PDL based on the review of the current evidence. To go ahead and change that PA criteria to update to align with the current guideline recommendations. Again, recommending to retire the ICS LABA specific criteria, and then to evaluate costs in executive session.
Good job. A lot of information. Thank you, Kathy.
Mm-hmm.
Questions for Kathy?
I think this is Mark. Sorry. I think my only question on this is like, if a patient is using inhaled steroid and salmeterol combination, do we think of that differently than if they're using uninhaled steroid with formoterol? Because it seems like those are actually very different in terms of the way that they're used. The recommendations for sort of smart therapy involve formoterol, not salmeterol.
Right, you're exactly right. The pharmacokinetics are different, and also that's a great point. I'm glad you brought that up. Formoterol and budesonide is really the only combination that's been studied for that smart therapy or as the reliever therapy in mild asthma. So we don't really have any specific criteria. I mean, that is a preferred agent, so providers can get that without going through any kind of process. But those are different. They aren't specifically addressed in the criteria, the LABA-ICS criteria. I don't know if there's a thought from the committee that you feel like that needs to be delineated specifically. We could definitely add that in there.
The reason I ask is because, if we eliminate the criteria that we had that were surrounding inhaled steroids plus long-acting beta agonists, then we fail to continue to have any differentiation between formoterol, which is, kind of now more of a first line with an inhaled steroid for a controller agent, but can also be used as rescue, versus the salmeterol, which is only really intended as an adjunct with a short-acting beta agonist. So I think that's where my confusion comes from.
Yeah, I mean, I think that's a good point. I think currently, as the criteria is written, they could get both those products without going through because they're both preferred. So I definitely see what you're saying. I'm just not sure we currently address it. I'm not sure that I guess I'm not sure the best way to tackle that, or if they would be prescribed or tried to be prescribed together, or
right. Because if your rescue medicine, there's two different scenarios. If your rescue medicine is budesonide and formoterol, and then someone decides, oh, well, you need to be on a controller medicine too, but I'm going to use a combination. Yeah, I'm going to use salmeterol and fluticasone. That would not seem to be supported by guidelines, but there wouldn't be any barriers to doing that. The other situation would be where you might have, I can tell you that 20 years ago, the guidelines were a lot simpler, where you could have a situation where you had fluticasone and salmeterol prescribed, and that's the only medicine the patient had on hand. And that would also seem to be a mistake.
Mm-hmm. Yeah, I definitely see what you're saying. I think I don't know the only way to address that other than make every LABA-ICS product non-preferred except formoterol budesonide, or require a PA for formoterol budesonide, which I don't think would be appropriate because, we want to encourage the use of that. So I definitely understand what you're saying. And I agree with you 100%. I'm just not sure the best way to ensure that it's being used appropriately without limiting access instead of opening access.
Well, what I wonder is if the right answer would be to limit access with a prior authorization to make sure that the patient has the right stuff to salmeterol and inhaled steroid combinations. So put a prior authorization on salmeterol ICS combinations rather than and no prior authorization on the other, since it can be used in both categories, basically rescue and controller.
Yeah, that's
true. Just have a duplicate therapy block where you have two LABA combinations and then it's a duplicate therapy, so that goes to PA.
That's not a terrible idea, but you still have the situation where if you have unfettered access to fluticasone and salmeterol, but you don't actually have a short-acting beta agonist, which you would need in that situation, you could run into trouble. And in fact, actually, that's what the study showed.
But if you just do long-acting beta agonist duplicate therapy, needing PA, then if it's just straight salmeterol or salmeterol combination, formoterol combination, that's when it go. But if it's like short-acting albuterol and formoterol, then it wouldn't block for PA.
I think that you wouldn't block formoterol under any circumstances. That the only one that you'd be concerned about would be salmeterol, and really it's the salmeterol in the absence of a short-acting beta agonist.
Would an idea be, just because I'm thinking about a policy that we implemented a while ago, and we did it as a safety edit when we were trying to prevent harm and ensure that people at the time were not getting monotherapy LABAs, and so they had ICS LABA prescriptions. But what we found out from that review is that we actually, it looked like there were more ER visits, and we were causing almost more harm than good in trying to implement the safety edit. And so we ended up abandoning that policy. Again, I could be articulating this a little bit. I mean, this is just from memory, but anyways, could we do something like a look back at, open it up, and then maybe see if there was a need to PA the fluticasone salmeterol, and then if so, proceed in that regard. So do it retrospectively instead of doing it prospectively, and just to make sure that there is a problem there before we limit access. It's just a thought, but.
Well, yeah, I mean, I actually think that the answer would be that we really would prefer that people were using the product that had the more flexibility, just based on the evidence and the guidelines, rather than encouraging people to continue to use ICS salmeterol. The apparently more beneficial product would not be that one. So it's a safety edit from the perspective of you don't want that as your only asthma medication, but it's also a clinical edit as well, based on what the guidelines say.
Could this be a place where we did some type of provider education? So if you're gonna, rather than do it through PA criteria, keep open access to both classes of agents, but do some type of provider education to encourage the use of the formoterol products. And then if they are going to use the salmeterol ICS combination, make sure that the patient does have a short acting like an albuterol inhaler available, and then do the look back after that. So we're keeping open access, but then just providing some additional education to hopefully drive prescribing practices versus doing it through a PA.
I think that's always a nice approach to it. I haven't found that to be historically.
I'm hopeful.
Yeah, it's a hopeful approach. That's what it is. Unfortunately, haven't been involved in that on other issues and this issue. I'm going to say, well, let's hope for the best of luck. But the other thing to do is to just simply leave it as we're suggesting here, and then come back and look at it in 6 months and see how many times the salmeterol combination inhaled steroids were being used in a way that appeared to be for acute treatment. And I think what you'll find, certainly it's what we found back in the early 2000s in Arkansas. I think what you'll find is that 80% of the prescriptions get filled once or possibly twice in a 6-month period. And so that suggests that those patients are, that medicine is being used as a rescue medicine, and that there was incredibly poor adherence. I'm happy to share my poster from 2005 if anyone wants to see it. So I think what you'll find is that anybody who's using an ICS with salmeterol is not very likely to be using it on a daily basis, which is really the requirement. And they're also very unlikely to have current prescription for albuterol, which I would suggest would be at least one.
What I'm hearing is a
recommendation to go and look at utilization following this policy change, specifically for ICS and salmeterol.
Yes. And to consider, how many times the salmeterol ICS combinations are being used without apparent access to a short-acting beta agonist, and to look at the adherence to that combination, but not necessarily the adherence to the formoterol combination, because the SMART therapy doesn't require you to use it on a daily basis.
And I'd still love to see the education, even though we all agree that it's maybe not going to solve the problem. I'd still.
Oh, yeah, I totally agree on the education. I just, especially with the new guidelines, I think that there's still a lot of people who are not familiar and following those new guidelines.
And we did do a newsletter on the new guidelines. And this year in April, as we mentioned earlier, and it does touch on that, but we could bring that back. That's no problem, and then, maybe actually a good time would be March or something in spring, when there may or may not be an uptick just because of allergies and stuff like that, and asthma exacerbations. But we definitely could look at that again. That's always a great idea.
I also think you can look at the dispensing patterns that you see with particular providers and provide them with specific education. So I think that there's absolutely nothing wrong with what's called counter marketing by people like Jerry Avorn. But I think there's no problem with targeting. When you see specific prescribers having a pattern where, you're using a lot of this particular combination, but your patients are not actually filling it in the ways that are consistent with the treatment guidelines. I think that might help to change prescriber behavior more effectively even than general education efforts. So a DUR process.
Yeah, those are great recommendations.
And Kathy, I totally agree with the timing. I think that bringing it back around, and honestly, it could even just be the same newsletter, maybe with a slightly stronger wording in the recommendation of the formoterol combinations, but essentially just re-release that newsletter in March.
So I'm hearing the recommendations. Oh, sorry, Mark, go ahead.
I was just going to say, this one too is one that would really benefit from a lot of coordination with the CCOs, because whatever is the predominant criteria that you have to follow is the criteria that you'll adhere to.
I definitely agree with that, because that is a big challenge that we face in primary care, especially a mismatch among formularies for ICS formoterol.
So I am hearing, in addition to the recommendations that are on the screen, to perform a policy evaluation in 6 months, to consider provider education and maybe some targeted outreach based on questionable patient filling patterns, and consider DUR coordination with the CCOs.
You're so good at this, Roger. Yes, I think that's what we're saying.
Do you want me to make that motion?
Please.
I'm happy to. Yes, what Roger said.
Second.
I say.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Good discussion. Thank you. Thanks, Kathy. Good job. Moving on, draw your attention to page 140 in the packet, and we'll turn it over to Sarah Fletcher for the influenza class update.
Thanks, Thanks, Roger. If you could go to the next page, I did a class update for the influenza drugs, and the purpose of it was to look at comparative evidence and new literature since the last update in 2019. Currently, we have basically 3 different types of flu agents. We have the NAIs, which include oseltamivir, zanamivir, which is inhalable only, and then peramivir, which is IV only. And then we have amantadine and romantadine, and then a PA-CAP dependent endonuclease inhibitor of baloxavir, which was approved just before the last time we updated this class. Currently, 3 of those agents, you can see listed below, have approvals for post-exposure prophylaxis, and then the full list of therapies is in Appendix 1, minus amantadine, because it actually falls in a different PDL class. If you can go to the next slide. Right now, for the background, the Centers for Disease Control have some recommendations for when flu should and should not be treated or prophylaxed. And in general terms, treatment can be considered in those with uncomplicated influenza within 48 hours of onset, but it only reduces the duration of symptoms by a number of hours, and the benefit is not that high compared to other populations. But it is recommended for patients who have hospitalization, severe or complicated or progressive disease, or at high risk of complications. And then prophylaxis is also not routinely recommended, but in certain individuals, especially those with high risk of complications or those who can't receive vaccines or where the vaccines may not be effective, they can have benefit. And amantadine and romantadine are not recommended for treatment or prevention because of widespread resistance with flu A. If you go to the next slide. Also, this is just a list of those who the CDC defines as high risk for complications. It's based off of age, comorbidities, pregnancy status, demographics, BMI, and residency status, whether it's in a long-term care facility or somewhere else. Next slide. I included only one systematic review in this for comparative evidence, and it was comparing peramivir and oseltamivir at treatment doses for patients who did have active influenza. And there was no significant differences in the total complications or in the differences in the rate of pneumonia between the two. This was like 4 different RCTs that ranged in size from about 34 to 500 patients, and it was mostly adults and older children. Next slide. I included one guideline as high quality methods, and that was IDSA from 2018. And I just want to note that that was prior to baloxavir's approval. So it's not mentioned in these guidelines just because of the date of approval versus the date of publication. They do recommend treatment with neuraminidase inhibitor, but not a combination of multiple of them for specific patients who are at high risk. And this does comport pretty well with what we saw in the CDC list earlier. So those who have hospitalization, regardless of how long they've had a duration of illness, those with severe and progressive disease, with complications, or meeting certain high-risk age categories. They also don't recommend the doses above the FDA-approved doses be routinely used. And yes, next slide. So looking at post-exposure prophylaxis from the IDSA guidelines, and these are very extensive guidelines, so they have different recommendations for different groups. I'm including the ones with the best evidence, but there's really not high levels of recommendations compared to treatment for some of these groups. But it is recommended for certain patients, and it can be considered if it's within 48 hours of exposure or for a longer periods of time in institutional outbreaks, but those aren't really included because we don't typically fill POS for those. But asymptomatic individuals who are very high risk, such as those who are immunocompromised, and in some situations, household contacts of those who are at very high risk who haven't been able to get a vaccine yet. And then the next slide. This one's a little bit newer, and again, the data with this compared to treatment is not as high quality, but I wanted to mention it because they did include an A2 recommendation for the duration of the season for a couple different specific groups who are at very high risk of developing complications from influenza. And those are ones who have recently had a stem cell transplant or had a lung transplant within the last few months. There's also recommendations for possibly using it short-term in people who are getting their flu vaccine, but it's not effective yet. But that one wasn't graded, but I do have those 2 groups listed on this slide. Then in the next slide, I included the American Academy of Pediatrics recommendations from last year. They're in the clinical context category because their recommendations are not graded and there wasn't a systematic review methodology, but they are heavily used and some of their recommendations are endorsed specifically by CDC. And so in children, Tamiflu or oseltamivir is the drug of choice, and it has the FDA recommendations for the youngest age ranges, whereas zanamivir is approved for older ages, and it's not to be used when there are lung diseases because it is an inhaled product. They also have some guidance on dosing for preterm infants, which the CDC specifically endorses. And just like CDC and IDSA, which I didn't mention, amantadine and romantadine are not recommended because of resistance, whereas the NAI and baloxavir resistance is being monitored, and there have been concerns for baloxavir resistance in places where it's heavily used. But a couple of seasons ago when it was last monitored, there weren't a heavy amount of resistance. We can go to the next slide. I'm not going to go through these, but I just wanted to mention that their definition of high risk for influenza complications is basically a very detailed list of what the CDC includes. It aligns well, it's just more detailed, and it's pretty much word for word the same list that the IDSA includes. So they all align within their definitions of who is at highest risk. And then the next slide, there are a number of different indications that have happened in the last few years. Peramivir now has an indication for patients as young as 6 months. Previously, it was older than that for those who are getting treatment. And then looking from the bottom of the page up, because of the chronology, baloxavir was initially approved for uncomplicated influenza, and then it was broadened to those who are otherwise healthy or at high risk of complications at age above 12. And then in 2020, a suspension was approved and it received a post-exposure prophylaxis indication for those 12 and older. And then in 2022, that was dropped to age 5 and older. So it's approved for post-exposure prophylaxis 5 and older. And it's also approved for 5 and older for treatment for those who are otherwise healthy. But for those at high risk of developing influenza-related complications, that age is still 12 and above. And there are also a number of safety warnings that have been added to the baloxavir label in the last couple of years. The warning and precaution has had a subsection added for hypersensitivity, and it has also had a subsection added for increased incidence of treatment emergent resistance in patients less than 5 years of age. And I want to just call out that that second one was not included in the final draft that was posted, but it will be in the archived document because it did meet within our literature search timeline. And next slide, there were 3 studies that did have comparative evidence. They weren't of exceptional quality, but I thought it was worth including them. The first is Baker et al., and it was treatment doses of baloxavir, oseltamivir in children, and the primary outcome was actually safety. There weren't big differences with the incidence, but the adverse events related to study drug, you can see it's higher for oseltamivir at 8.6%. But it's a 5-day treatment course versus 1, and most of those were gastrointestinal. So there were no serious deaths, adverse events, or hospitalizations to differentiate the two. In the Capstone study, it was treatment doses of baloxavir, oseltamivir, or placebo in patients 12 and older. And they used an interesting time to improvement of influenza symptoms with a composite of 7 different symptoms of cough, sore throat, headache, nasal congestion, feverishness, muscle and joint pain, and fatigue. And there was a number of hours to improvement, and there was no difference between the baloxavir versus oseltamivir for a number of hours to having the improvement of influenza symptoms. And adverse events were similar across groups, and they were actually highest in the placebo group. And then lastly, on the next page, there was a 3rd trial, and this one was 2 different doses of peramivir. Of note, neither one of them are the FDA-approved dose. FDA approved is 600 one time, and in one group, it was 2 daily doses of 600. The second group was a single 300 milligram dose, and then it was the appropriate normal treatment dose for oseltamivir. And this was in adolescents and adults who did have treatment. And this was another non-standard endpoint. It was the cumulative area of time versus symptoms, and it was expressed as an AUC, but lower numbers are considered better. And there was no difference between the higher dose peramivir and oseltamivir. There was a statistically significant difference in the lower dose peramivir versus oseltamivir, but I think it's difficult to interpret that given the unusual nature of that endpoint. As far as safety at the bottom, the higher dose peramivir had 25% treatment emergent adverse events, which was higher than either of the other 2 groups. And again, that dose is not an FDA approved dose. So if we go to the PA changes on the next page, on the first page, we wanted to just clarify where the PA was being applied, but also I want to call out the change in the oseltamivir therapy. Currently, oseltamivir is the only approved agent, and it isn't PA'd for treatment. Oh, can you go back one slide? Sorry, it's not PA'd for treatment doses, which are 5 days long, but all prophylaxis was being PA'd. And in light of the flu season, that could be significant, especially with what we're seeing with RSV and the short time range for when you can start prophylaxis in patients for whom it is appropriate. I wanted to change that so that Tamiflu doses that are 7 days or less, which would be prophylaxis doses, could go through without prior authorization. If you go to the next page, question 4 is just a change to for things like the Tamiflu, where it's not approved in certain populations, but it is compendia supported. So I was just clarifying that. And question 5, baloxavir, that's related to using it for prophylaxis, and it now has the indication for that. So I've added it to question 5. The next page, this one is mostly a clerical. These changes are just clerical. And if you go to question 7, I've added pre-exposure prophylaxis in line with what IDSA had for that specific subset of patients that's at very high risk that could qualify for very long prophylaxis, rather than having, if we did have someone who'd had a stem cell transplant, having to get a denial and go to appeal and go through that process in the middle of a flu epidemic. I wanted to have that, or not an epidemic, but a high flu transmission situation. I wanted to have that in the PA up front to make it a little bit easier if we ran into that situation. So the last slide, the recommendations right now are no changes in the PDL, but to update the prior authorization with what was presented, which includes the expanded indications and would allow for the age ranges of peramivir and baloxavir, because we don't restrict upfront very heavily on those right now. We're trusting the providers on that. And then to evaluate costs in executive session. So can I open it up to any questions?
Well done. Thank you.
Thanks.
Move to approve.
Second.
All those in favor?
Aye.
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 Anyone opposed? And abstain? All right, thank you.
Good job, Sarah. All right, moving on to our last topic. Starts on page 160 in the packet of materials, and we will turn it over to Deanna.
Thank you, Roger. If we can go to the next slide. If you recall, we just looked at topical agents for atopic dermatitis back in June, and we discussed vitiligo, but we didn't go into a lot of detail about topical agents for psoriasis. So we've had 2 new therapies that were recently approved for topical treatment of psoriasis. So that's really what prompted this review. So we'll be talking about roflumilast and tapinarof, which both have kind of unique mechanisms of action. If you're interested in the PDL status, it's in Appendix 1 on page 184. Next slide, please. So there was 1 systematic review and 2 guidelines. The systematic review was a reevaluation of safety of the topical calcineurin inhibitors, which is pimecrolimus and tacrolimus, because there is a box warning regarding the risk of cancer, primarily lymphoma, associated with the TCIs. And this systematic review showed that there was no association between TCIs and overall cancer risk, but there is moderate quality evidence that shows that compared to non-active comparators or topical corticosteroids, that the TCIs had an elevated risk of lymphoma. So this just reinforces some of the other data that had come out when these drugs were first released. Next slide, please. Okay, we had two guidelines. The first is this July 20 update from the American Academy of Dermatology and the National Psoriasis Foundation. So they went through a pretty extensive review of all the topical agents. I just summarized the high quality evidence or moderate to high quality evidence. Not surprisingly, topical corticosteroids are recommended for mild to severe psoriasis that doesn't involve the intriginous areas. And then there's good evidence for topical vitamin D analogs, that is calcipotriene or calcitriol. And then using the combination of the topical corticosteroids with tazarotene is also recommended. And then coal tar still makes the grade as well. Next slide, please. So in 2019, as I mentioned, we haven't looked at topical anti-psoriatics since 2017. There was some guidance about using some of these treatments in pediatric patients, and many of the topical corticosteroids are not FDA approved, but they are recommended off-label for treatment of pediatric patients. And then there is a combination product that contains the vitamin D analog and betamethasone. Those are FDA approved for use in children that are 12 years and older. So these were the guidelines from that society. Next slide, please. So there's a lot of new indications, especially for the topical corticosteroids. Those are all summarized here. What I really want to highlight is ruxolitinib, which we reviewed earlier this year. It was originally approved for atopic dermatitis. Now it has improvement for vitiligo in patients that are 12 years and older. So this is essentially the first FDA approved drug for treatment of vitiligo. Everything else is off label. Next slide, please. So moving into the new drug review, roflumilast is a selective inhibitor of phosphodiesterase 4. So it has that approved indication to use for topical treatment of psoriasis in patients that are 12 years of older. There were two randomized control trials that led to the approval. If we can go to the next slide, please. Page 176 has the complete comparative evidence table. This is just a extrapolation of the highlights. These were two similar trials. They included patients that were aged 2 years and older that had affected body surface area 2 to 20% with mild to severe psoriasis. The exclusions were if they had above normal exposure to the sun or tanning beds, if they had any kind of psoriasis other than plaque psoriasis, if they were taking oral roflumilast or other PDE4 inhibitors, or if they were taking some cytochrome P450 inducers or inhibitors, because there are a lot of drug interactions with this drug. So the primary outcome was the proportion of patients that had IGA success at week 8, which is a score of 0 or 1, so clear or almost clear, and then plus a 2-grade improvement from baseline. And you can see that compared to the placebo vehicle or the inert vehicle, that roflumilast had good results in both studies. And then the secondary outcome was the proportion of patients which achieved PASI 75 at week 8. And again, we saw good results with number needed to treat of 3 to 4 for both studies. Next slide, please. Some of the limitations of this trial was because it was a inert vehicle, we don't really know what the comparative efficacy is with other agents, for example, topical corticosteroids. It was only an 8-week trial, so relatively short. And although it's approved for use in pediatrics, the number of children and adolescents that were enrolled was very small, 18 out of 881 total participants. Next slide, please. Clinical safety. So there was very low rates of application site adverse effects that were observed with the roflumilast. Interestingly enough, with a topical agent, we saw diarrhea, headache, insomnia, and nausea. As I mentioned earlier, there is some metabolism through the liver, so it is contraindicated in patients with moderate to severe hepatic impairment due to the risk of systemic absorption. And then some of the drugs that tend to interact through the CYP3A4 or CYP1A2. So got some examples there. Those should be cautiously co-administered with this topical agent. Next slide, please. So the other new drug we wanted to look at was tapinarof, which has a unique mechanism of action. It's an aryl hydrocarbon receptor agonist, which appears to contribute to the pathogenesis of psoriasis. Like I said, it is a new mechanism of action, and it's approved for topical treatment of psoriasis in adults. So there were 2 trials, if we want to go to the next slide. Very similar to the ones we just looked at with roflumilast in terms of, this was just in adults aged 28 to 75 years old with mild to severe psoriasis and an affected body surface area of 3 to 20%. Any other psoriasis besides plaque psoriasis was an exclusion. These were over 12 weeks, again, compared to an inert vehicle. And for the physician's global assessment, we were looking at, again, clear or almost clear, and a 2-grade improvement from baseline. And you can see they had good results compared to the inert vehicle with numbers needed to treat of 3 and 4. And similar results were seen with the PASI 75, which was a secondary outcome. Next slide, please. So they were missing a lot of the data, and so they used multiple imputation to adjust for that. And again, this was relatively short, 12 weeks, and it was compared to an inert vehicle. So we don't really know how this compares to some of the other agents that are used topically for psoriasis. Next slide, please. This is clinical safety. There was a lot of folliculitis that was observed compared to the inert vehicle. And then some of the other things that are on here, like contact dermatitis, headache, itching, and influenza. Next slide, please. Thank you. So these are our recommendations. I really wanted to get to this because the PA criteria has been changed quite a bit. So we're going to revise the PA criteria for topical agents to include ruxolitinib, which has that approval now for non-segmental vitiligo. And then we're going to designate roflumilast and tapinarof as non-preferred and revise the PA criteria to include the guidance that's in the PA. In other words, they have to meet HERT guidance, they have to meet the age approval, and they have to at least try 2 moderate to high potency topical corticosteroids for at least 4 weeks before trying these. We talked about the EPSTD changes earlier, so we're going to update the PA criteria very similar to what Sarah showed us earlier. So we're going to remove, previously we had a PA for all preferred products. We're going to allow the preferred products to go through without PA for children and adolescents. And then for non-preferred, there will be PA criteria, and that's to accommodate the EPST guidance. And then we're also going to add the medications that have been in the topical anti-psoriatic class to the topical agents for inflammatory skin conditions, and we'll evaluate costs in the exec session. So I'll go through the PA changes real quickly. Next slide. So the biggest thing on this first—
Deanna, 1 second.
Yes.
Apologies. I see Bill's hands up. I don't know if that's—
Oh, I'm sorry. I didn't see that. What's the question, Dr. Orger? I'm sorry.
Oh, I just have a comment that probably won't change the conclusions, but I was not impressed by the success rate of either of these drugs. Both of it had a success rate, give or take, of 30% compared to placebo. So that means about 70% of the people failed the primary endpoint compared to placebo. That's not very good. And so position as a secondary treatment behind the standard treatments, I think, is very appropriate.
Fantastic. Thank you. I appreciate that. And I am kind of going through this rather quickly because we're at 4 o'clock. So thank you for bringing that forward. All right, so changes to PA criteria. On the first page, we're just going to restrict the dermatologic drugs for funded diagnoses for adults. And as we've talked about the HERC guidance quite a bit, but basically the only thing that's funded by HERC are the severe inflammatory skin diseases, and they're all listed there. And then we've added this standard EPSDT language about allowing a case-by-case review. The other thing I wanted to bring forward is under requires PA, the second bullet, I've neglected to add psoriasis there. So all topical medications approved for treatment of atopic dermatitis, psoriasis, and vitiligo for adults 21 years and older will require PA. So essentially, this means PA is not required for the preferred agents for patients under the age of 21. I really want to drive that point home that that's a big change. If you want to look at the PA criteria, they're on page 188 of the packet. So one thing that we did, this was Sarah's very clever idea, was to add evidence supported indications for the topical drugs to this table. So we have a question that just says, is it an approved indication? So this is a new table. Next slide, please. This is another new table, which is recommendations of topical first-line treatment options based on disease severity. And you can see the corticosteroids and the TCIs come in first place pretty much for atopic dermatitis, plaque psoriasis, and then for vitiligo as well. Next slide, please. So some of the changes are on question 2, we have the division between if they're over 21, if it's not severe inflammatory disease, it will be denied for not being funded. But if they're less than 21, we'll go to question 3, make sure it's one of the diagnoses for the covered indications, and then make sure that they meet the age requirements, which are listed in table 1. Next slide, please. And then this is the other standard wording that we've added in question 6 about is there documentation. This follows the standard language that we've been using. And as Sarah mentioned earlier, if we need to modify this to comport with what HERC has suggested, we will, but we're trying to make sure all the PA criteria have similar verbiage to be consistent across the board. And then the final question we have here is the request, if it's for an FDA approved question number 9, either approve it or not. If it doesn't meet psoriasis, vitiligo, or atopic dermatitis, it would go to that question. And I think that's it. Is there any more? Nope, we don't have any public comments. So if you would go back to the recommendations, Sarah, thank you. So this is the question is, does this meet with the P&T committee's approval to follow these recommendations for the changes to the PA criteria?
Move to approve.
Thank you, Bill. Do we have a second?
Second.
Thank
All
you,
those
Mark.
in favor?
Aye.
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 Anyone opposed? And abstain. All right, thank you.
A lot of information again. Thank you, Deanna. Great job. I now have to read my radio voice, our blurb before we go to executive session. Sarah's been setting up the breakout room for the committee to go over there. No decisions will be made there, but we will be reviewing confidential pricing. So the P&T committee will now meet in executive session for the purpose of the consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to RS 1926602F and RS 4143561 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with the requirements of ORS 414353. Representatives of the news media and designated staff shall be allowed to attend the executive session. All our members of the audience will be left in the outer session and not permitted to attend. Representatives of the news media are specifically directed not to report on any of the deliberations during the executive session except to state the general nature of the subject of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. We are returning from our breakout room from executive session. Give us a moment here to get situated, make sure everybody, we have our quorum and we have people available to vote. So for those brave souls remaining in the audience, just give us a couple minutes here, please. And would the P&T committee please unmute your lines? I'm doing a head count. 1, 2, 3, 4, 5, 6, and the 7 members. I see all unmuted your lines. Fantastic. I appreciate that. So after review in executive session, I'm going to present the recommendations, lump them together, unless I hear any opposition. So one of the classes we reviewed were the growth hormone class. After review of executive session, the recommendation is to make Nutropin AQ Nu-Spin non-preferred. For the drugs for asthma and COPD class, the recommendation is to make Combivent Respimat non-preferred and to make Spiriva Respimat preferred. In the influenza class, after review and exec, recommendation is to make no changes to the PDL. For the topical products for inflammatory skin conditions, we already had made some recommendations during open session based on the clinical information. After review of confidential pricing exec session, the recommendation is to make Tazarotene gel non-preferred. And I believe that's all the recommendations. So with that, are there any questions? And if not, we need a motion to approve.
Motion to approve.
Second.
All those in favor?
Aye.
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 Anyone opposed? Oh, sorry, everybody.
Does that count as an opposed?
I don't know. Yeah, I think they're opposing whatever it is. So
No, that's
we're not going to count them though.
All right, that sounds like a
Sounds like a vote.
Were approved unanimously. So with that, that concludes our December P&T meeting in the 2022 sessions. The next meeting we have is slated for February 2nd, 23. With the exception of Mark, we will be contacting you, maybe have some orientation with the new members that are coming on board. But Mark, just wanted to once again thank you for the 4 years you've been volunteering for this important work, everything you do in the state. And we continue to hope we get to engage you as we move forward with our process.
Oh, thank you. And it's been a pleasure. Feel free to reach out. I'll do my best to get back to you.
Fantastic. Thank you, everybody. Have a great holiday season. Be safe out there.
Happy New Year.
Thanks, everybody. Happy holidays.
Bye.
Bye.
Bye.